With coverage of ASH 2015 in Orlando, I'm Thomas Baldrick, joined now by Dr. Rami Komrokji. He is from the Moffitt Cancer Center in Tampa, Florida. Thank you, sir, for coming by.
Thank you very much.
Let's talk about your study here, validation of International Working Group Response Criteria in Higher Risk MDS. What was the purpose of doing this research?
So in patients that are classified as higher risk MDS, the purpose of treatments that we administer are usually to improve the survival for patients and try to alter the natural history. Obviously, allogeneic stem cell transplant remains the only curative option, but when we look at medications, the goal of the treatment, obviously the main goal is improve survival, but also obviously improve patients' blood counts, maintain their quality of life. So the way we judge the responses are usually by a set of criteria called International Working Group criteria. Those are criteria that were proposed by a panel of experts originally back in 2000, and they were modified or revised in 2006. Those mostly were based on data, but also some of them were consensus. They were not data driven. And those are currently used in clinical trials to judge efficacy of treatment and in real life to judge if the patient is benefiting from treatment. Now, and they are different categories. That in the revised one, for example, there was a suggestion that there is a group called MARO-CR, that if patients have less than 5% blasts without a count improvement, those patients could be considered as responders, which have never been validated to know whether they really benefit from treatment or not. Based on historical data, the only kind of analysis looking at the response criteria and their correlation with survival comes from a study of azacitidine, the main study that led to the approval by the FDA for azacitidine, called azacitidine 001 study, AZA 001, where a landmark analysis showed that if patients had a complete response or a partial response or hematological improvement, they had a survival advantage. So, but outside that context of that study, those criteria had not been validated. So the aim in our study was to look at those criteria to see, do they correlate with survival, do they correlate with AML transformation, and try to get an impression, are those criteria helpful to develop drugs? Should be looking at those criteria to get approval for drugs.
How do you see IWG criteria being used in practice?
Right, so actually that's a very good question. So I have to say there's probably discordance between their use in clinical trials and real life. First, in many cases in real life, in older patients, bone marrows are not repeated. So in higher risk MDS patients, if that's not done, you cannot assess a complete response, MARO-CR or partial response. Some of them are difficult to assess, like if we look at something called hematological improvement, that could be an absolute increase in the hemoglobin of 1.5 grams or more, but sometimes that could be 4 units of blood transfusion reduction over 8 weeks anytime during the course of treatment, which in reality is very difficult to capture. So I would say your question is very valid, that there is some discordance between their use in real life and in clinical trials.
Where do you see this criteria playing a role, if you do, with the FDA approval process?
Right, so obviously they are crucial for two parts. In the early phase of development, you cannot always perform studies to look at overall survival or leukemia transformation, because by nature those studies would be very large studies, would require so long time. So usually we try to develop what we call surrogate markers of response or surrogate markers of survival to start the early studies, and if you have enough, signal of response, then you will move to bigger studies. So we were interested in that part. Like, so if a patient achieves a complete response or a partial response, would that be enough signal in an early phase 1, phase 2 studies to then say we are going to take it to the next level?
What would be the next level for you in this area?
Right. So what we saw in our experience, obviously, there were more than 600 patients that had higher risk MDS, that they were treated for their disease. And we saw, we looked at the best response for patients, and we saw that patients that achieved a complete response had the best outcome, with a median survival exceeding the 2 years almost. They had less leukemia transformation, but there was also benefit for patients that had partial response, hematological improvement. The number of patients that achieved that MARO-CR was small, but it's not clear that those patients really drove benefit. So our thinking or conclusion that basically a complete response partial response or hematological improvement could be reasonable endpoints in an early study, and probably a complete response should be the endpoint for a phase 2 randomized study. And if there is enough efficacy for the phase 3 studies, obviously overall survival still remains the gold standard.
Very good. Thank you, Doctor. We appreciate you sharing your time with us.
Thank you very much. I appreciate
Very
it.
good.
Thank you.